It's a real pleasure to be with you today, and we'll talk about how to monitor disease activity in this very complex disease. Here are my disclosures. And all rheumatologists know that it's very important to consider several elements in patients with SLE. We have to measure disease activity for sure, but it's not the only element. We have to be aware about damage, comorbidity, also drug toxicity in our patients, and of course, all these elements could deteriorate quality of life, and we have to measure that. Disease activity is very important in every lupus patient. All of us know that. And this is a very heterogeneous disease. And when we think about disease activity, we should think that this is a continuous variable. All of us know that this is a characteristic that can fluctuate even in the same year. So it's not the same in every clinical encounter. And it's very important to distinguish disease activity from disease severity. We can have an active patient who does not have a severe disease. All of us know that. And we have to measure that in order to do a good clinical practice. When you talk about disease activity, you're going to find some related terminology. And we have to think about global scores or organ-specific disease activity. This is very important in terms of treatment. And we measure disease activity because we want to treat that. And we want to measure if the patient is responding. And we talk about partial or complete response. And if we have complete response, there is another terminology that you're going to hear more and more. That term is remission. What do we mean by remission in our patients? And some patients, if we measure disease activity and it deteriorates in the next visit, we can think that this patient is having a flare. So that's another related term that we have to be aware of. When we talk about disease activity measurement, we have to take into account several concerns. It's very important to make a difference between activity and damage. Is this patient with an abnormal urine test having an active renal disease? Or is that a chronic damage in that organ? All of us know that pregnant lupus patients will have clinical and laboratory abnormalities that sometimes are very difficult to distinguish between normal things and clinical disease activity. People who see children are aware that sometimes it's very difficult to have the symptoms from a very young population with lupus patients. And this is a challenge too. And all of us who see patients have every day this clinical discrepancy. We have a patient with clinical normal data, but one lab test that is abnormal. What to do with that? Do we need to treat those patients? This is something that Dr. Jurwitz will talk later. And all of us want to do something that could be easier in our clinic. We are expecting those biomarkers that could tell us how things are going in a simpler way. I think that we are not close to that yet. So, how do we measure disease activity and what for? This measurement is essential for clinical decisions. All of us do it, and we should do that at every clinical visit. And there are a couple of ways to do that. One is informal evaluation versus formal evaluation. And we have to distinguish clearly. We're talking about our clinical setting, daily clinical practice, or are we doing that but also with research purposes, or we are involved in a clinical trial? It's quite different, and I can show you that. Most of us are clinicians, and we want to measure disease activity. And daily practice requires some important methodologic and practical issues. First of all, it has to be feasible, it has to be simple, it could improve the time that we take care of our patients. The scoring should be simple. We use that for our patient care. The information is office-based, and we put that in the clinical chart. That's clinical practice. But if we do research or clinical trials, everything is quite different. All of us know that. What we do most of the time, and I will say 90% of rheumatologists will do an informal evaluation. And we decide that one patient does not have disease activity, or mild, moderate, or severe. We do that all the time. And we treat our patients based on clinical judgment and some lab results. And we measure that again next time to see if the patient is responding. But I can advise you to go a step further. Try to use visual analog scales, not only none, moderate, and severe. Try to go and measure that in a more standardized way. That will be an advancement. But if you really want to do it properly, I know that it's time-consuming procedure, but it's a much better measurement. Try to go to use a formal evaluation. And we have validated instruments, many of those. By using these instruments, you decrease variability because you have definitions. And if you respect them, you're going to have a formal definition and a measurement that could be the same by different evaluators. And you do a systematic evaluation. You do not forget this variable because it's there and you have to score that. And all of us are aware that to do it properly, some instruments require training. You need training to do that properly. But very important, if you measure disease activity, please register that in the clinical chart. And in order to do that properly and useful for your patients and your clinic, try to do it at every clinical visit. You're going to ask me, okay, there are many clinical indices around. Which one do I want to use? Well, first of all, some background about clinical indices. They have clinical data and also laboratory variables. Most of them will have a time frame. Some of them will have a treatment attempt. Most of these instruments are very static. How is your patient today? And some of them will have transition questions. How was your patient last month and how is he doing today? And some of them are very global, most of them I would say, and some of them are organ-specific. So which one to use? The one that you think will be useful for your clinical practice or whatever purpose you're trying to reach. Some examples of clinical indices: global scores, the SLEDA, the SLEDA 2K, the Mexican version of that, MEX-SLEDA, the SLAM, or the ECLAM. Some organ specifics, the BILAC index, or the CLASI. And if we want to use that in clinical trials, we want indices that will detect when the patient improves. And we have some examples of those. Just a quick review of some of these commonly used instruments. The SLEDA 2K scores 24 manifestations in 9 organs or systems. I will say that that's the most popular and used clinical instruments in the world. You score one of these manifestations if it is present, and if you attribute that to SLE, it could go from 10 to 30 days according to different versions, and the scores will go from 1 to 8. Disease activity could be as high as 105, and the clinical meaningful change could go from several publications from 3 to 7 points. The BILAC, this is the instrument that is very commonly used in clinical trials because it measures disease activity by organ and system domains. It has 97 variables in 9 systems. You score them as not present, 0, improving, same, worse, or new compared with the previous month. That's a transition index. And the domains are scored with letter A to E based on intention to treat. A means a severe disease, and E, no disease activity. A response index, the SRI, you have been listening to that in several presentations in this meeting. It was a post hoc development and published by Dr. Fury and collaborators in 2009. It requires 3 different variables, at least 4-point reduction in the Selena SLEDA, no byline worsening, and no physician global assessment worsening. You require those, and it was a very important contribution for one of the clinical trials in drug development, and it has been used for other clinical trials. It's not the only one. There is another response index called the BICLA. That's a composite response index based on BILAC, and it's the primary endpoint for 2 clinical trials. It was published and presented by Dr. Wallace at the ACR 2 years ago. One example of an organ-specific disease activity index is the CLASI. This is a cutaneous disease activity and severity index. It takes into account erythema, scale, mucous membrane lesions, and non-scarring alopecia. Visible areas such as face and neck will get higher scores, and clinical improvement is associated with a 3-point decrease. I want to make some recommendations. First of all, if we want to do things properly, if we want to treat better to our patients, if we want to contribute to knowledge in lupus care, we have to implement formal evaluations of disease activity in our practice. We have to be very careful to registry and do it the same in the follow-up. It's very important to evaluate how useful is that in our practice, and I'm sure that all of us will be eager to listen from your experience. Please share your results in these clinical meetings.